probably add, also be inviting you. But then let me tell you one thing, that we have a major event coming up, and that is this virtual. Now, this is what I'm saying. This actually is a virtual conference. And we have Dr. Ravi Choi. Now, he doesn't need any introduction. I think most of us have his textbooks kept on our tables. For me, at least, their Bible. Then, he's going to be taking us through 3 days on the 12th of July, the 19th of July, and the 26th of July. He's going to take us through first trimester, fetal brain, and fetal heart. And these sessions are going to be between 1 p.m. to 5:30 p.m. So, first of all, if you have not blocked yet, block these dates. Secondly, you need to register, because if you ask me why register, first of all, of course, it's a great academic event. It's going to be a great academic event because he's probably the finest speaker in fetal ultrasound. So academics, is always been there in SFM, and it's going to be there. There's going to be a virtual trade exhibition. Now, why do we go for conferences? We go for academics. We also go for, we want to see an exhibition, the trade exhibitions. And thirdly, we want to meet our friends and talk to them. So we're trying our best that you would be able to chat with your colleagues also during the conference. So really giving you, so it's not a webinar. And I would say that yes, you need to register for academics, but also do register for getting a feel of what a virtual conference is all about. And if we need to, because see, we are in it for a long time, at least for the next 6 months or 1 year, we are going to be in with virtual conferences. So this is probably the first one on ultrasound which is going to take place. So for the feel of a virtual conference, just to know how virtual conferences are all about and what kind of job we are trying to do, I think all members should need to register for this. And early bird registration ends on 1st of July. You need to go to www.sfmvirtual.org. And then I want to, for this first meeting, we normally have our meetings with local flavor, but then because it's a virtual meeting and because of the pandemic, both the stars are not traveling anywhere. So it was easy to catch hold of them and get them for this particular event in the evening. So we have Dr. Ashok Khurana, Dr. Praveen, and Dr. Aniruddha Kulkarni, 3 very, very big stalwarts in the field of fetal ultrasound. And I hope you're going to enjoy this next 1.5 hour with them. And Dr. Ashok Khurana, see, if you tell me that, can you read out his CV? First of all, you can't put his achievements into one CV. So, and if you want me to read his CV, then you'll have to give me a separate lecture for that. So that's not possible. So let me tell you one thing. He doesn't need any introduction, but yes, he is the past president of the Society of Fetal Medicine, and he is now at the moment the mentor emeritus for the Society of Fetal Medicine. He's actually the founder member of Society of Fetal Medicine. He's the man who's responsible for getting all of us who love fetus under one umbrella, and he's eventually got us together. We interacted with each other, we taught each other, and finally we are going and achieving his aim, which was to give every fetus an optimal outcome. And sir, thank you very much for actually starting this, getting us together, and today, thank you very much for accepting this invitation of the Marathwada chapter. Then we have our dynamic president, Dr. T.L.N. Praveen. Again, a lot of times it's very difficult to get his dates, but let me tell you, it's about both Dr. Khurana and Dr. Praveen. One thing is there are people who've actually complained that they both are a little partial to Aurangabad. This is one discussion I was having with some people in one conference, and they said, how is it that Aurangabad always gets them very easily, gets their dates very easily? Praveen sir has, from the time I started my practice, that was the time I heard him first in Aurangabad, and really want to thank him. He's never said no to any invitation to come down to Aurangabad. And even today, of course, not just because he's the president. Yes, I could, it was like he had to be there today for this particular event. But every time we have asked him, we have requested him, he's always been there. And thank you, Praveen sir, for doing that. He's, of course, now our acting president until, and he is taking SFM, what it has started, and he is taking it ahead with his own vision about SFM, and the vision of the previous presidents, and taking it forward. And I am being fortunate that he's been mentoring me also all along, because for everything that he's doing, he's helping me out, mentoring me for the future. And thank you very much for that. And then our local tadka, Dr. Aniruddha Kulkarni, using the word local tadka is wrong, because he is a national and an international figure. But Ghar ki murgi dal barabar, it has always been the saying. So, but for us, Aniruddha is our own Aniruddha, and so definitely a local tadka for us. He is, a great teacher. He's the academic coordinator of the Scholar MD Gynae program, and his fields of interest are endocavity ultrasound and neck imaging and genitourinary and gynae. So we have all these three stalwarts who would be taking us through, and it won't take too much of time. But lastly, to thank the Medisense and Mindray team, Praveen and Manoj from Medisense. These are two guys who have actually, every time SFM had a meeting in Aurangabad, they've come forward and participated. And, it's not just about participating for the event. They come forward, they visit my clinic every day, they ask for any work to be done. And thank you, Praveen, and thank you, Manoj. And then Shivangi Trivedi from Mindray, and thank you, Mindray and Medisense, for providing this platform to us. So with that, we move to our first lecture by Professor Ashok Khurana. He is going to, fetal medicine is not just ultrasound. Yes, fetal imaging is a major part of it. Genetics comes in very, very strongly. But there is no sense in genetics unless there is ultrasound. So the phenotype and the genotype, both the things are very important, but there has to be a synergy between the two. And so in the new era, it's ultrasound meets genetics, and that is what Dr. Khurana is going to take us through. Welcome, Khurana sir, and the stage is all yours. I will unshare my screen so that you can share your screen now. Sir, please.
Yeah, a very good evening, and I am so pleased to truly be here. And I hope the sound and the screen are coming out fine. Am I audible enough, Bimal? Yeah, wonderful. Thanks so much. It's always so exciting to be in Marathwada. I cannot define it, but there are a lot of beautiful things in life which you can't define. You just enjoy them because they're fantastic. And it's not just Bimal, Aniruddha, or the city. There's something vibrant about everyone there. I've been to Nanded, I've been to Bede, I've been to several places in that area, Ajanta, Ellora. There is a lure over there which goes beyond fetal medicine. And with the regional chapter becoming so vibrant, as you just heard from Bimal, we're only too pleased to be a part of it. And now I have a whole new executive committee to support me, and I can truly enjoy what I do, which is teaching, and leave all the hard work to them. I will, of course, continue to take credit for everything without doing any of the hard work. And what I'm going to take you through now is what Bimal told you, and that is ultrasound meets genetics. And in this, it's actually something where I want you to know that this is a whole new era. Not because we have all these fabulous images as you see over here. No, it's not just because of that. It's not just because we've evolved from knowing that the skin was too loose for a baby with Down syndrome, or that Benacerraf described the fact that the nuchal skin fold would be thickened between 14 and 20 weeks of gestation, or that Nicolaides told us that yes, we have fluid accumulating at the back of the fetal neck, or the fact that you have to do an ideal crown rump length as the beginning. No, it goes way beyond that. It's actually that we realize today, as Vimal has told you, that the phenotype has a tremendous bearing on getting to the genotype. And it was always there. You had to have quality ultrasound. But we've now reached a new era where things are just so completely different. We do understand that there is something new that has happened. The last time something new like this happened was in 2006 when Eveville told us through the editorial in the White Journal that, look, we've moved from obstetric ultrasound to ultrasonographic obstetrics, which means that you cannot take the next step unless it is dictated by ultrasound. And pretty much so, the same thing has now happened with genetics. That we used to think that genetics belonged to the labs. We sent them a scratchy note or just half a phone call, and that everything would happen. That is not happening anymore. Genetics is now totally phenotype driven. And this is something that I will let you know about in the next 20 minutes. Because as you see here in this article from the Lancet, they talked about whole exome sequencing, which is something we will discuss today as well, in the evaluation of fetal structural anomalies. And this is in the Lancet of 2019 and actually got published this year, it got accepted last year, that in the analysis done by this fantastic group on the whole exome sequencing data, in a prospective cohort of fetuses with structural abnormalities, the value of whole exome sequencing following the use of routine genetic tests suggests that when the conventional karyotype failed to show an abnormality and the chromosomal microarray failed to show an abnormality, there was a whole lot of contribution by whole exome sequencing. And so we entered this new world. We knew that things were changing. Things would always change. For instance, look at this. Volume 178 of the AJOG in 1998. And Better Benacerraf tells us that karyotype evaluation is recommended when isolated clubfoot is identified on a prenatal ultrasound because other subtle associated malformations may not be detected in the early second trimester. And we lived with it for a few years because we weren't the smartest. But look what happened now. In 2000, we are very, very clearly told that, look, isolated clubfoot diagnosed prenatally is karyotyping indicated. And 4 years ago, 4 years before March 2000, we heard that, look, you have to do a detailed ultrasound and you don't need to do any further. But what we know now, as of this month, is that, look, if we have prenatal clubfoot and we do a microarray on them, then we will find that even if it's an isolated abnormality, 3.9% will have an abnormal genetic result, which means that these fetuses are not completely normal, which means my thinking changed from, look, I wasn't doing good ultrasound, so I needed amniocentesis. I was doing good ultrasound, so I didn't need anything else, to something that, look, there is much more to bilateral club feet, and we should not just put them all together under the same umbrella. And therefore, whenever I see club feet from now onwards, I'm obliged to offer my patient an amniocentesis and a possibility of a chromosomal microarray, because it will give me information that will help me prognosticate that pregnancy. And we've seen it happen. We know that a clubfoot can progress to fetal akinesia syndrome. We know that a clubfoot can progress to the dustbin diagnosis of arthrogryposis, and we know that they can recur. Yes, sometimes with no other consequence and they can be repaired, but the fact is, to make sure that patients make intelligent choices, we have to keep pace, and hence the new era, that the phenotype is now directly going to indicate how hard, how beautifully we have to actually handle the genotype. So I will take you through routine first trimester genetic screening and where we stand today. And we'll add a word on second trimester genetic screening. We will also discuss imaging and clinically directed genetics in the first and second trimester, and also imaging directed genetics in the third trimester as we go along. Not very formally, because that makes no sense in a forum like this, but at a very practical level to tell you that, look, we have to evolve, that genetics changes, but ultrasound changes much more. And today, a good ultrasound will be the only way you can get good genetics. If you don't have a good ultrasound, you will get horrible genetics and you will underexploit what the world of genetics is all about. Of course, to remind you that we have screening tests and we have diagnostic tests. And in the first trimester, blood tests on the mother, such as the Pape and beta HCG, is one of the screening tests. That an ultrasound done between 11 and 14 weeks is a screening test. And that non-invasive prenatal testing on maternal blood is the most advanced screening test for an aneuploidy in terms of sensitivity. On the other side is the diagnostic test, which confirms the diagnosis of a screening test. A screening test is never a diagnosis. It always needs to be elaborated by a diagnostic test. And this either rules out the genetic problem or confirms it. You need to get either coronary sampling, which we do between 11 and 14 weeks, or we do an amniocentesis anytime between 16 weeks onwards, and we get a final diagnosis. Remember that we can never terminate a pregnancy on the basis of a screening test alone, and we must always confirm it. The advantage of most screening tests is that they do have a high sensitivity, and NIPT, for instance, has a sensitivity of greater than 99%. But the specificity is very important because the positive predictive value is not so high in any of these tests, and therefore we need invasive testing. There is one more input that we get in the first trimester, and that is that if we know that the parents are carriers of various conditions, and we will discuss these, this would have been either noticed because they had a previous sibling with the problem, or there's a family history of the problem, or just on what is now available, a routine carrier screen for parents to be. We found something that needs analysis. In that case, again, at 11 to 14 weeks, one would undertake a corneal and villus sampling. So this is what is available, and this is the background that we've been working with so far. What we have to move beyond today is to realize that there is more to life than a conventional karyotype for an abnormality or a positive screen, that there is more to it than a QFPCR or a FISH for aneuploidies, and that we now have a chromosomal microarray, which is of two types, an array CGH and a SNP. We also have things like single gene detection and gene panels. We have a whole exome, or we might just trim it down for the sake of costs to a clinical exome, and we have whole genome. And I promise you, these words are not going to be strange words, and I'm going to put them into an appropriate perspective as we go along. Remember also, at the same time, we've had tremendous progress in invasive procedures. When we first started amniocentesis, we used to tell everybody 1% miscarriage. We got better. We said 1 in 200. Then we said amniocentesis is a little better than CVS. And then we said, okay, both are equal and it's 1 in 500. And then until a few months ago, we were saying 1 in 1,000. But this absolutely brilliant paper in the White Journal, 2019, halfway through last year, tells us that in experienced hands, the invasive procedures do not have an increased risk of miscarriage. There is a background risk of miscarriage in any pregnancy, and this is the same story. That we have a background risk here, and therefore the patient will miscarry, not something that is procedure related, which means that every patient must be offered diagnostic invasive testing in an appropriate perspective, and there is no harm in doing so. Tomorrow, a patient would have can say that, look, this is quoted in this paper, and why didn't you tell me? I would have taken that option. Not that they would have taken an option. You and me know when we deal with patients that they don't take this option. But the fact remains that we must tell them that this is the best, this is the second best, this is also possible, this is also possible, this costs this much, this has limitations. So we have to have a cafeteria approach. You and me are not gods in heaven. You and me are waiters in the cafeteria. We kneel down and say, okay, ma'am, this is our menu for today. These are the specials for today. And this is our standard menu. Now you choose. And that has to be the appropriate thing that we have to do. And these are recommendations now also by the American College of Obstetricians and Gynecologists. And of course, ISWAG endorses this because it appeared in their journal for the first time. And then to remind you, of course, that a screen is what we offer to everybody, and a diagnostic test is not necessarily that is taken up by everybody because they can be expensive and some patients will still be scared. Screening, of course, doesn't give us a diagnosis. It gives a low risk for a particular condition or a high risk. It's offered to everybody. It's simple, it's accessible, it's affordable. It has low false negative results like we discussed. And then, of course, it can lead to increased false positives, but that's acceptable. And ultimately, there is the diagnostic test, which has potential risk. So we don't do it for everybody. Potential risk because not every one of us is the best kind of person in terms of being an expert in invasive procedures. And also because nowhere in the world can they offer this as a free test. There is a cost to it. The taxpayer is paying for it or somebody's paying for it. And therefore, we must remember that we still follow this business of screening versus diagnostic testing. But a patient has a right to refuse screening or any testing, and a patient can go straight on to diagnostic testing, such as sisters who have a brother, for instance, with Down syndrome. Moving on, the next thing we have to realize is that when we talk in screening, we have either a patient or a family history, and we have ultrasound and biochemical markers. And sometimes it's easy. You can spot that this is truly a little rhinoceros in the middle of an elephant. And sometimes it's not so easy because this is an owl amongst the pussycats. And so you may not have the smart thing. And that happens in trisomy 21 a lot. And of course, we must also realize that sometimes it's very, very simple because something stands out like a Hitler among Mother Teresa's. So if that is so, then we say, all right, we are quite happy with this sort of a situation. And we can go ahead. And this is almost like a diagnostic test, like NIPT, for instance. But nevertheless, in a screening test, you still need a diagnostic test. The way you do that is to do a procedure, which can be amniocentesis, like I said, between 16 weeks and beyond. Don't do it between 14 and 16 because it could result in oligoamnios, it could result in limb defects and facial defects. And the cells are so few that they may not grow in the lab, and that can be tricky sometimes. You do a Scorion villus sampling, which is done between 11 and 14 weeks, and that's usually done now transabdominally. Very, very rarely one might have to do a transvaginal route. And some people prefer for a quick diagnosis of chordocentesis, but this is almost not done. The only place where we now really use a chordocentesis is not for genetic diagnosis, but for confirming a fetal hematocrit, such as in rhesus isoimmunization. And then we will go ahead to tell you all the tests that actually happened today. Also, that you must get familiar with the reporting format. Some of them are pictorial, like a fish sitting over here, or a fish for deletion 22q11 sitting over there. And then there are some which are now just texts, such as the microarrays that we come across. And the important thing is that this is not just me talking about all this, but a lot of what I'm talking today is endorsed by the American College of Obstetrics and Gynecology and the United States Society for Fetal Medicine. And there are several practice bulletins, several committee opinions that clearly say that ultrasound imaging gives us a phenotype and that the phenotype drives the steps towards the genotype. Now, therefore, I will take you through what are increased risks of fetal chromosomal abnormality, how do we handle it, then the other genetic abnormalities. Of course, you might also require sometimes non-genetic conditions such as perinatal infections to be confirmed. And then, like I mentioned, a maternal request where you just do it because the patient wants it and the patient has a right. And you write it in your notes that, yes, the patient insists on invasive testing. So the invasive testing is being done. She doesn't want to be screened. She wants to go straight ahead. Completely justified. Remember that in all of this, including screening, including diagnostic testing, counseling is extremely important. The patient must know all the details. Counseling is beyond today's talk, so I won't talk about it in detail, but counseling is essential not only for the patient to understand and make the right choices, but also from a medical legal point of view. And we are shifting more and more to video counseling and, of course, and always written informed consent. Now, some of the basic stuff before we go ahead, we have the old-fashioned stuff, which is the numbers of chromosomes, and we call them aneuploidies. And then we have structural abnormalities, which are translocations, one piece of a chromosome getting cut off from here and getting attached somewhere else, either on the same chromosome or another chromosome. Deletions, which is missing genetic material. duplications, which is too much of genetic material, and single gene defects. And this is a pictorial representation here that you have DNA, which is a combination of 4 possible amino acids, you know those. They're bound in pairs and double helix structure. And then nucleotides are multiple segments of these DNA base pairs. And when a bunch of nucleotides get together, that forms the gene. And a bunch of genes get together, and that forms the chromosome. And therefore, we can either look at the whole chromosome or we can look at it in bits by bits as we do here. And genetics today can tell you about this, genetics can tell you about this, and genetics can tell you about this. And we will discuss how we go about that. Because now, genetics looks deeper and deeper. So it's pretty much like this. You're up in the sky, and you're very high. And you see the forest, and you see a bit of civilization, and you see the sea. And then you come in, and then you can see, okay, I see some houses, and I see this little hotel on the edge of the sea. And then I go down, I can see some lanes, and then I get into this house. And in the house, I see a chair, and I see the cushion on it, and I want the design on the cushion. Now, why am I saying this? I'm saying this because this is the conventional karyotype. Everything that you want to know in large numbers, no detail. If I want a quick result, I will use a QFPCR or a FISH, and that'll tell me in 2 or 3 days, is it 21, trisomy 21 or not. When I do a microarray, whichever type I want to do, either the the array CGH or the SNPs, I am actually looking a little further. And then if I'm looking at the whole room, I know that is my whole exome. And if I want to look even further at a small group, that is my clinical exome. And then, of course, there is something which has just moved from the realm of research into the realm of clinics, and that is the whole genome. The whole genome looks not only at the active genetic portions, which are called the exons, but it also looks at the introns, which is the space between the genes. Very expensive, but maybe useful in certain situations. We won't discuss about that too much today, but we will certainly tell you which of these we use where and how we use it. But essentially, we go deeper and deeper and deeper, not just the whole chromosome, but the copy number variants, as they called, in microarray, and then, of course, single genes or a sequence change, and different tests detect alterations in different number of base pairs. The word used there is base pairs. So here we are. How do you and me figure it out? Not really. There is no shortcut to this, and there is no way that I, as an imaging specialist, am ever going to be able to understand which test I need where. We will talk about it, yes, in the next 15 minutes, but what I really need to do is to communicate with the geneticist, and that's not just WhatsApping everything. No, that makes no sense. What you and me need to do is to call directly, because these are always done on an urgent basis. There is always that 20-week deadline, which hopefully will change in the future. But meanwhile, we must communicate directly, because you want to know, is the lab opened or closed? How do I send the sample? How much sample? What is the cost? What is the turnaround time? And if I'm looking at this particular finding on ultrasound and this particular blood test and this particular family history, what is the best test? And the geneticist might turn around and say, look, what the best test is such and such, but that is available only in, say, Syracuse, New York, or it's available only in somewhere in Greece. What do? Well, it's easy today. You send it by courier. And then they will tell you, okay, you send it to us and we will handle the rest of it. And they will then communicate. So geneticists have their own networks. You and me have our own networks. And we always work for the betterment of the patient by realizing that, yes, there are many options. We will understand these in the next few years as we go along. But currently, we need to communicate with the geneticist all the time. Going back to the numbers, when you have a total number of chromosomes, which is abnormal, like the trisomies, for instance, that is what ultrasound genetic screening is all about in the first and the second trimester. And when you have the structural stuff, the translocations, the microdeletions, the microduplications, single gene defects, and so on, then there are two aspects for ultrasound. One is, of course, single gene defects, family history, previous child, carrier screening. You do an ultrasound guidance straight for invasive testing, which is CVS in case the patient comes early, or an amnio in case the patient reports late. On the other hand, in a lot of these conditions today, we have realized that a very careful ultrasound will tell you about associated structural defects. One anomaly, two anomaly, multiple anomalies, typical group of anomalies. And that will then guide whether I will do a microarray. And usually that is always done. That today we do a quick video microarray, which gives us a result between 7 and 14 days, depending on how busy the lab is. And you can do it on cultured and uncultured DNA. But more importantly, if that comes clear, we move to the next step, which is a whole or a clinical exome. And in case that also doesn't yield and we have a group, you can still store the DNA. So ultrasound will guide you through these steps and make sure that the patient gets the final report. And even if they don't get a report on why things went wrong, the DNA is there, that as and when, tomorrow, day after, next year, 2 years down the line, when science makes progress, we will understand things better. Let's just store up the DNA, and it costs nothing because the DNA is actually being extracted for the rest of the tests anyway. Now, the common aneuploidies we all know is trisomy 21, 18, 13. You also have monosomy X, Turner syndrome, XO, triploides, and the sex chromosome abnormalities. And Down syndrome is the toughest one because it's the commonest cause of congenital compromise of IQ. And a lot of patients today would like a reproductive autonomy, as we call it, which means the right to terminate a pregnancy. A bit of controversy on that in different parts of the world, but let's face it, in our part of the world, even people who brought up one baby with Down syndrome, the vast majority would not be happy having a second baby with Down syndrome, or even the first baby with Down syndrome, and they would like to terminate that pregnancy. And so that is where the whole story started, looking for Down syndrome. We'd moved on from spina bifida in the 70s and the early 80s. By the mid-80s, we were doing second trimester Down syndrome, and now we're doing first trimester Down syndrome. And luckily, we can diagnose this in pregnancy. And we can diagnose it better and better. We started with just maternal age, which would diagnose 30%, a triple test, which would diagnose about 65%, a second trimester quadruple test, which would diagnose about 75%, a first trimester combined test, which takes us to about 80 to 90%, and NIPT or cell-free DNA in maternal serum, which takes us to almost 100%. And do remember that even in invasive testing, it's a 99.9% accuracy, and we can have a false positive or a false negative, and that can happen. So do remember there is no 100% test. And again, this is part of your counseling for your patient. But one of the reasons why things improve is that we are trying to improve detection rates. Also, we're trying to push the calendar and try and get a first trimester diagnosis so that termination is easier and safer, more private, and psychologically much, much, much easier. We also like screening tests simply because we want them to yield a lot more without invasion. And some of these tests have evolved because our NTs were no good, and therefore biochemistry made progress. And biochemistry sometimes is no good, so our NT becomes smarter and smarter, and we keep adding additional markers. So this is the reason why we're now in a very commanding situation where we have advanced biochemistry and advanced ultrasound, good quality ultrasound, and that can give us some fantastic results. Most of the stuff is done in the first trimester, and sometimes, of course, the patients report late in the second trimester, which is not unusual in our part of the world. Now, I've already mentioned that ultrasound and biochemistry are screening tests, and in ultrasound for populations, that means large numbers offered to everybody, public hospitals, it's a combination of NT, free beta HCG and PAPA, and maternal factors. And then, depending on whether you get a positive on that screen, we'll do invasive testing or give the patient the option, and then she can decide. And it tells you about the risk numbers, and then you understand what is truly going on in that particular situation. Now, the important thing to realize is that there's a huge difference in the first and the second trimester detection rates. In the second trimester, the triple test gives you only 60 to 65%, and that's not good enough because we know from the recent recommendations of the ISPD and the American College of Genetics that you have to have a detection rate of 75% for a test to be truly worth it, and it's not acceptable to have anything less than that. And that maternal age alone is no good. That a nuchal translucency is 75 to 80%, which is good, but it improves a lot more in case you combine it with beta HCG and PAPA, and that gives you like a close to 85 to 95%. By itself, first trimester biochemistry is again not good enough, and it's only 60 to 70%. And if you combine increased number of markers in ultrasound, such as the nasal bone, tricuspid flow, or ductus venosus flow, you can go up to a 96% detection rate, and importantly, a false positive rate that goes down to 2.5%. So truly speaking, this seems to be a great answer for population screening today. And this has been known for many years now. Now, the other thing that we must understand is that the whole thing is always interpreted in terms of maternal weight, ethnicity, IVF, number of fetuses, maternal diabetes, and smoking. And there are no shortcuts to that. You have to have that, and not that the NT is thick and therefore invasive testing. No, always put it into perspective. Yes, the NT is an independently very, very powerful marker. But in order to reduce the amount of false positives and to increase the false and make sure that you don't get too many false negatives either, it's nice to always work around all the markers. Now, once this is done, we're already familiar with this, that you have three groups. The ones which are very high risk, where you usually offer invasive testing as a first possibility. But remember, no directed counseling, let the patient decide. Most patients, somewhere between 1 to 1 and 100, would say, okay, I'll try NIPT first. Some would say, no, okay, I'll go in for invasive testing. If the risk is less than 1 in 1,000, that means 1,000, 2,000, 3,000, all we do is, okay, come back for your second trimester anomaly scan at 18, 19 weeks, and we'll include a genetic sonogram. And in the intermediate ones, where you have a score of, say, somewhere between 1 in 50 to 1 in 100 to about 1 in 999, that is where they suggest that you should do the additional markers or an NIPT. And this is known as the contingent model for NIPT screening. So these are the various options that are available to us. But like I said before, remember that the triple test is not the test of choice that drives genetics anymore. No question. Your imaging will be dashed completely in case you use a triple test and you don't use a quadruple. Ideally, of course, you should do everything in the first trimester. When NIPT came along, we thought, okay, this first trimester is going to go out of the window. What do you mean it's going to go out of the window? Well, it is, because you have a test here at 10 weeks and you take blood and you get your answers, and you know that the risks are very, very low, like almost nothing, and it works well. No, the story is that if you don't have enough of the fetal DNA going around in the maternal circulation, then you're going to have to not get the right answer. It's called the fetal fraction. And typically, if it's less than about 3 to 4%, then the accuracy of NIPT is no longer, the detection rate is no longer 99.6%, as we call it. It falls to about 96%, which is the same as your first trimester combined screening. And therefore, you will always need a first trimester scan, because you need to know about the number of fetuses, whether the fetus is alive or not. Also, if the pregnancy is less than about 10, 11 weeks, you don't have that much fetal DNA circulating, and then you can go wrong. So you have to date a pregnancy very correctly. And if the mother has a BMI that is too high, say more than about 24 or so, again, there's going to be not enough of fetal DNA because there's too much maternal DNA, and that's not good enough. And therefore, for all these reasons, the first trimester screen is here to stay. And so if you're going to do that, then you may as well go ahead and do everything else, including a screening for preeclampsia, which is far more common than Downs, growth restriction, which is far more common than even preeclampsia, and preterm birth by looking at the cervix, which is far, far more common than all of these put together. And therefore, the first trimester scan is here to stay, and therein is our secret, that it can also assess for structural defects, and this will then guide what you do. We no longer do a karyotype. We always now end up doing, for an early diagnosis, a FISH or a QFPCR, and otherwise a microarray, and that is the recommendation of bodies all over the world. Remember that we like to do this at the right time, not too early, also because our fetal imaging is much better after about 62 millimeters of round rump length, and that is important. There's no doubt that biochemistry performs much better in the beginning. That means at about 10 weeks in terms of PAP-A. The difference between the euploid and the aneuploid fetus is a lot in terms of the low PAP-A at 10 weeks. In the HCG, it's about the same. And therefore, a lot of people say biochemistry at 10 weeks. But for patient convenience, we do it actually all at 12 weeks. But ideally should be done at 10 weeks. And because our fetal imaging is much better after about 62 to 66 millimeters, we like to do all of these at 12 weeks plus. What about second trimester genetic sonogram? Well, some patients have missed out on it, and therefore this is the only option we have. Then sometimes we do it between 14 and 18 weeks because we had a first trimester finding, but patient doesn't want invasive testing. Or that the patient has a finding and a positive screen and still doesn't want invasive testing, and of course in patients that just don't end up on time. In this situation, then we look for various markers, and importantly, we do mathematical calculation. That is beyond today's talk today, but we have this wonderful chart by Gatha Clois, and we have a baseline, and here we will use our first trimester combined risk as a baseline, or whatever other features we have as a baseline, and then multiply by these. And for each of these markers, you have a positive multiplication factor and a negative multiplication factor, and then you get a new risk, and we use it in the same way. But that's not what we're here to discuss today. What we're here to discuss today is that, look, sometimes right there and then, in that mid-sagittal view, and this is a slide from Ravi Chavi, which he showed at the ISWAG meeting in Berlin last year, you could find ventriculomegaly, and you say, okay, I need to investigate this differently. You could find anencephaly, and you know that this is to be investigated differently. You know you can have a megacystis or an omphalocele, and that is to be handled differently. You can have a cystic hygroma, which again has to be handled differently. So there's a lot in ultrasound that would even then override what you have to decide in the first trimester, not just Down syndrome, but a lot more. And then you decide whether serial follow-up, reevaluation at 14 weeks or 16 weeks, or invasive genetic testing. The whole thing is image-driven because you're doing a detailed evaluation. If one view in the mid-sag can tell you so much, certainly the complete survey can tell you a lot more. And so everything now, even in the first trimester, is overruled by imaging, because that will then guide what is happening rather than just a trisomy 21. For instance, here, we have a normal gap between the two frontal bones at 11 to 12 weeks. And if I have premature closure of the metopic suture, I know I will always get a trisomy 13. This is invariably going to turn out to be trisomy 13. It got confirmed on a fish, it got confirmed on a karyotype, and anyway, after the fish, the patient had decided to terminate the pregnancy. So what is happening is that we are rewriting the books not only of embryology, but also genetics straight away as early as 11 to 14 weeks. It's the same thing with the skeleton. We know that we can now pick up an excellent view of the skeleton, even in terms of 2D and also in terms of 3D. And what happens in this situation? You realize that, yes, there is something wrong with the skeleton. You can either do surface mode on 3D, you can do skeletal mode on 3D, or just a very good 2D, and realize that, yes, indeed, here is a situation where I just have to investigate further. And that is where we say, okay, we may not be able to identify the type of dysplasia, but we can actually start looking for particular types. And the next step, I have a dysplasia, and suddenly my geneticist tells me, look, hold on. The FGFR3 gene, which you're thinking of, and is so common in several skeletal dysplasia, including achondroplasia and thanatophores and some of the others, can actually be found not only in Corion Willis sampling, but also in NIPT. So if it can be found in NIPT as well, I know, okay, my image has now to be very sensible. And if I want to make an early diagnosis of achondroplasia now and confirm it, I will not have to wait until 26 weeks. The patient has an option. We know often these are de novo, there's no family history. Then what do? The patient doesn't want invasion as yet. You do an NIPT. And depending on the NIPT, then you can actually say, okay, then in that case, if my FGFR3 is negative, there's a possibility that this is non-lethal. We take a chance or we don't take a chance. Again, patient option. What has driven this whole thinking of patient option and invasive versus non-invasive? A detailed evaluation of the bones at 11 to 14 weeks of gestation. There are, of course, additional genetic windows, like sometimes we have a single gene defect that has to be looked at even without abnormal imaging. You do a sex determination. Again, you have to be very sensible about this. We in Delhi are very, very privileged. I'm in a district called the Southeast District, where the appropriate authority and us work together. They call us for their seminars. We go for their seminars. We invite them to ours. We think alike. And therefore, we know where it is legal, where it is not. But you have to find out what is your local environment and then decide. On the other hand, there are certain situations, such as a previous child with a disorder, where again, you might want to do genetics on the basis of a family history. And then, of course, a fetal demise, where again, you might want to investigate. Then the genetic windows that can happen is that you just store up the DNA, and if something shows up later in pregnancy, you can analyze it. But do remember that even if you discover something much later in pregnancy, say 26 weeks, and you discover short long bones, or you discover a duodenal atresia, or you discover a renal abnormality, and that's not unusual at all, or you discover a late onset ventriculomegaly, then here you can carry out genetic testing at any time in pregnancy. There is no limit to genetic testing when you can do it. There is the MTP law, yes, but that is different. This is to prognosticate the patient, prepare them for it, and decide whether they need referral to a tertiary center, the mode of delivery, operative versus non-operative, and then, of course, any guidance for the patient that, look, soon after birth, you have to start rehabilitation, and this is the best way to do it. So MTP may not be an option, but there are a lot of other things that you have to think about, plus the prognosis of future pregnancies. We know that post-mortem material often is not good enough for genetic testing, and you need antenatal material, and the best thing then is to do it and keep it and make sure you use that information in the next pregnancy. Now, for early diagnosis, what we've conventionally always used is a FISH or a QFPCR, and then we've always used conventional karyotype. We no longer just do that anymore. What we do is that we've replaced it. What we've also done is realized that there are some where, like I said before, we just look at the previous history and we realize what is to be done, and here we don't have to look at imaging. We do an invasive procedure, ultrasound guided, and the main function here is the guidance for chorion villus sampling and, of course, a detailed first trimester scan. Otherwise, your main aim there is to just get the DNA, and that's what single gene disorders are all about. The big new step, of course, is the chromosomal microarray, and it is now recommended that if you have fetuses that are normal on the karyotype, you might pick up almost 6 to 13% extra abnormalities if you do a CMA, and that the chromosomal microarray is now the test of choice. If that comes normal, you can move to the next step, which is the whole exome sequencing, where it can add up a lot, and we will discuss that towards the end of my presentation. What do these tests do? QFPCR and cell-free DNA give us a quick diagnosis, particularly for trisomy 21. The FISH is exactly the same, and we will discuss a little bit more that, look, FISH is something that is labor intensive and therefore may not be the first choice because we don't get labor so much anymore. Chromosomal microarray picks up copy number variants or the breaks or the duplications or the changes of a much, much smaller degree than what conventional karyotype picks up, and therefore it goes deeper into the genome. And then, of course, you have whole exome, which goes even deeper, like we have already discussed. Currently, what we follow is that, look, we will do first a QFPCR to exclude the trisomy 21 wherever necessary, and then a chromosomal microarray. And after that, you decide on the exome, and we always do it as a stepwise fashion. Occasionally, in some countries, such as in Germany, because microarray is not covered by insurance and exome is covered by insurance, they jump to exome straight away. But truly speaking, we just go first by a microarray and then an exome, and the karyotype is not really done too much anymore unless you're suspecting a translocation type of condition. So the story so far is what we handle in the first and second trimester. That in the economically privileged patients, the first trimester screening should be an 11 to 14 weeks complete assessment on the scan, plus a first trimester's combined screen, plus PLGF for her preeclampsia risk, and an NIPT for making sure that we have greater sensitivity. It's not possible for everyone. For population screening, it's as I said. And in an institution, if you don't have these facilities, mention it that these are my limitations. We don't have the money, or we don't have the staff, or we don't have the machines. And therefore, this is all we can do. And it should be put to the reports as well. The moment you get a structural finding, encourage at that time invasive testing. And then, of course, you must understand that if you do only NIPT, and that's again come out in a beautiful paper by Kati Bilardo a few months ago, that if you do only NIPT, you will miss out a large number of significant abnormalities and a lot of genetic abnormalities as well. Microarray is now something that you must do. And of course, monogenic disorders will be missed, but those will then have a history, no doubt. Also, you might have balanced translocations that you can miss out. Triploidy can now be picked up. It gives you quicker results in the karyotype, and you can use it on any tissue, even in a stillbirth tissue. You can use it on placental tissue, you can use it on amniotic fluid, cord blood, heart blood, and therefore you can do all of that. And that is one of the advantages of a microarray. The problem is that sometimes you can have benign variants, you can have unrelated pathogenic variants, and variants of uncertain significance. We make a noise about them today, but tomorrow we will learn, and I promise you, we will have better results. The cost, of course, of a microarray a little more than karyotype. There are two types. There is the array CGH and the SNPs, and the SNPs has an advantage, and that is the technique to go. And so check with your lab that they're offering you SNPs, smaller microdeletions, low-level mosaicism, triploidy, uniparental disomy, and long continuous stretches of homozygosity will be picked up on a SNP microarray, and therefore you have to do that. And I must thank Dr. Ratnapuri for giving me this slide, which sort of hits you in the face and tells you, make sure that you choose the right microarray. There are two types of microarray. The SNPs is the right microarray. And this is a chart that we've already discussed, that yes, the karyotype is okay, but not as good as the old CGH, and the SNP array is the best. And then, we pick up the more common things. Some of them are very well defined, and they have ultrasound findings. And the moment you do that, you can pick up all these copy number variants. And this is from a recent paper. Also, the more the number of anomalies, the more the chance of picking up one of these. And so again, the phenotype. For instance, if I find a heart defect, I know that I must do a 22q11 deletion study, which again, I can use a fish like we used to use, but more and more of us are now doing a microarray. And that tells us very nicely about the 22q11 deletions as well. And this is something that you and me will become familiar with as time goes by. You can't learn it overnight, but we will learn it from time to time. And then you have, before we move on to the whole exome, gene panels, which are like for skeletal dysplasia, fetal achiniasias, you have some genes and you put them together. And these are totally dependent on ultrasound finding. That means I find an achinasia syndrome, I will do a certain set of genes, because genes are expensive. A single gene is expensive to handle, and panels are therefore more expensive. Or you have a skeletal dysplasia, and therefore you have to do it. And then again, you have to make sure that you're doing the correct one, the right kind of gene panel testing. And that again, like I said, the first step is ultrasound findings. You describe them, you give a phenotype, you give what is now called a phenome and not a phenotype, and then you get a genome. Like this one, for instance. We had here a fetus that showed us the classical agenesis of the corpus callosum and hemispheric cyst, a cataract, a depressed bridge of the nose. MRI showed and confirmed the agenesis of the corpus callosum. I knew that the genes I had to look on were these, and we looked for those, and then we realized that, okay, there are 3 well-defined phenotypes, and this was a classical Walker-Warburg. Now, this can only come with a dialogue, with a very, very careful evaluation of all the abnormalities. I must look at the lens always. I must look at the cataract always. I must have access to 3D, and I must use MRI sensibly. That phenotype will determine the best and most intelligent and cost-friendly way to get to a genotype. And therefore, I'm talking about a new era. And then that brings us to exome sequencing. And I know I've overshot my time, but I'll take only 2 minutes more. The exome analysis is about 2% of the genome, and that's responsible for the protein coding. The whole genome is different. The whole genome is the whole genome, and that is a lot more and more expensive. But the exome and the constitutes what is called the exons, and exons and introns make the genome. So in exome analysis, we do the exomes. You can either do the whole exome, which is what they use in the United States, but most companies realize that is expensive, so they reduce it to clinical exome, which means you have a finding, and on the basis of that, you choose a set of exomes that you're going to look for, a set of genetic abnormalities you're going to look for, and that's called a clinical exome. And most of us now do a trio analysis, which is patient plus parents, so that at the same time, we can get more information and more direct information. This was first reported for fetal achinasia sequence and recurrent pregnancy loss. But now we find that you get excellent results in skeletal abnormalities, craniofacial abnormalities, multiple abnormalities, and also the turnaround time is a little longer, so you have to be careful, and skill is required. So again, you have to be careful, but realize that an imaging phenotype is central to the choice of clinical exome, and it reduces the cost and complexity. And that's where we come in as specialists in fetal medicine, that we give fabulous images, and then we will be able to get the answers. If you have 1 or 2 or 3 or 4 abnormalities, you get a greater result on the exome studies. And like I said, craniofacial and musculoskeletal, excellent results, and to a certain extent for all the other groups as well. So that we move from an answer not just in 10 to 15% of abnormalities, but to almost 60% of abnormalities as having a genetic basis and following up further. And this is what is now recommended, not as first-line study, but in a strongly suspected abnormal phenotype. If the microarray is normal, you then move on to an exome study. Now, remember that everything is important as a starting point. And it's not just that we call this a thickened nuchal translucency. No, this is a cystic hygroma. This is a possible cystic space in the posterior cranial fossa. I will put these together and then decide what I have to look for. Sometimes it could be a trisomy 21. Yes, it could even be a monosomy X, or it could be something more complex. And so I must keep my mind open and realize. And sometimes I must also realize that they not have any of this to do with the diagnosis. And all I might be looking at, as you see in this video, is that we have leaves and leaves of amniotic sheets and bands that are creating havoc, which may have caused the disruption in the first place. So remember, you have to think not only genetics, but think beyond genetics as well. To wind up, let me say the most important thing remains to communicate with the geneticist, and then you will do a good job. And this is going to be my closing slide. This is the best way to go about it. And thank you very much for this opportunity. My apologies for overshooting, and Bimal, forgive me for that. And to remind everyone to register as soon as possible for Ravi Chavi's talk. And thanks ever so much.
Thank you very much, sir. Overshooting, this was actually, it is, I know this topic is such, it's very difficult to put it into a short span, but so I think you've still not overshot, because this whole thing requires a complete session to be to cover up all this thing, but putting everything together and concising into one talk. And thank you very much for I think a lot of people today must have got aware about what test is, what are the types of tests, what are tests. And I think one strong message which goes from this talk is that, yes, we need to investigate. We need to at least give an option to the patient that, yes, there are chances, there are tests available, we can go ahead and do it. If they're willing, we need to go ahead and do it. Thank you very much, sir. I now invite Dr. T.L.N. Praveen for his presentation on the area behind the heart. Basically, when we look at the area behind the heart, there is nothing gross that you make out which tells us there is, or tells us towards a particular pathology. There are always very, very subtle findings in the area behind the heart, which actually tell us that, yes, we need to look further. And then that leads us to very, very important cardiac abnormalities, which have outcomes. The prenatal diagnosis makes a huge difference in not only giving an option to the parents to terminate the pregnancy, but also making these babies deliver in a tertiary center, because it has been proven over a period of time that a lot of these CHDs which are prenatally diagnosed have better surgical outcomes if they have been diagnosed prenatally. So I now invite Dr. T.L.N. Praveen. I request him to share his screen.
Thank you, Vimal. I'll just share my screen 1 second. Let me open up my...
And your video also, sir.
Yeah, pardon me?
You have to... We're not able to see you.
I don't know. That's what I don't know. 1 second. 1 second. Let me get again. Yeah, 1 second, because I don't know. It's again gone back to launch meeting.
Okay, sir. Should I take do one question in the meantime, sir?
Please, go ahead. Go ahead.
These are two questions to Khurana, sir. One is, in this era, can we go ahead and use telemedicine for counseling patients in fetal medicine?
Of course. No
Officially,
doubt. We can very, very comfortably go ahead and do counseling. The fact is that what is happening is the other way around. You are using imaging as the basis. So your counseling is going to happen on the same day, which means that you have got the images correct, you are working correctly on that, and you have your answer and counseling on the same day. But if it's somebody else's images, you don't know how much to depend on them. You can do telemedicine and telecounseling, and it's perfectly legal. But the problem is that how much can you depend on someone else's imaging finding? And that is very, very critical. But legally, there's no problem.
Am I visible? My screen is.
Your screen is visible. You're audible, but you're not visible, sir.
Yeah. I'll see. I don't know where to get. Yeah. Okay. Yes. Am I now visible? Yes. Right. Thank you very much, Bimal. And thank you very much, Marathwada group of the chapter of SFM. You have been academically very, very vibrant. I really congratulate the whole team for organizing such wonderful events. And it is purely academic, and it is so enthusiastic group that it has a very vibrant WhatsApp group where they really share wonderful cases. Now, before I waste time on this aspect, because we had a wonderful lecture by Dr. Ashok Khurana, and it was really a great mind opener, and then we learned a lot from it. Now, as it's a huge talk, I agree, because it's very difficult to compile it within a specific time period. So anyway, we have a small presentation that is what's called as the area behind the heart, which actually is a quest for certain subtle signs, which is very, very important for us. Now, whenever we try to evaluate the fetal heart, we go by what is called a sequential examination. We start using what is called as the sweep technique, where we start from the fetal abdomen, evaluate the fetal stomach, location of the aorta, location of the inferior vena cava, then sweep your transducer cranially so that you can see the first section that you see in the fetal heart is the four-chamber view. As we all know, the four-chamber view is the easiest view that we can all obtain, and most of us try to get it whenever we start off examining the fetal heart. There's actually the actual section of the fetal thorax, where we look for certain important structures like the presence or absence of the chambers, the disparity between the sizes of the chambers, morphological features, also the interventricular septum, and then the atrioventricular valves, and then the foramen ovale with the flap. Now, these are the ones which we normally also look for. Now, when we come to the recognition of the chambers, we always say that the posterior-most chamber is the left atrium, anterior-most chamber is the right ventricle. And when you see the posterior-most chamber, that is the left atrium, you do find at least two pulmonary veins draining into the left atrium, as you can see here. Now, once you see this one, when we call it as a posterior-most chamber, that is because it is related to the posterior structures, that is the vertebral body and the descending aorta. So these are the things that we are going to look for, and this is what is called as the area behind the heart, where these are the structures which we are going to look for in this particular aspect of evaluating the fetal heart. Now, what is the impact of this area? Whereas we all know that it is just an extension of evaluation of the four-chamber view. It has to be done, and it enhances the screening potential of the four-chamber view. What are the points that we are going to take into consideration while evaluating this area? One and most important thing is the number of vessels, or you can call it as tubes, behind the heart, and their laterality. That is very, very important thing that we have to keep in mind. Now, when we come to the normality, what we have to see is that you normally see only one vessel, that is the descending aorta, and you also see that it is just behind the heart, and it is left of the spine, and it corresponds to the side of the cardiac apex. This is a very, very important statement. Left of the spine, side of cardiac apex. That means in case if it is a dextrocardia, where the apex is onto the right side, you do see that the descending aorta is on the right side. That is one important statement that you should always keep in mind while evaluating the laterality of the fetus. Then comes when you start using high resolution scanners, you can also see the small semi-hemizygous. Now, what are all the things that we can make out? The most important thing is the fetal cardiac defects are quite often associated with right-sided location of the aortic arch. So when you do a 4-chamber view, you find that the descending aorta is onto the right of the spine, you immediately know that you need to search for the cardiac abnormalities. That is one aspect of it. Not only that, for the heterotraxy syndromes, they are usually associated with 2 vessels. What are those 2 vessels? One, in a left isomerism, what do we have? We have what is called as the interruption of inferior vena cava, and that results in the systemic communication through azygos continuation, which appears as a double barrel sign. And whereas in a right isomerism, what happens is there will be malposition of inferior vena cava, and then the aorta and IVC are parallel to one another and they are on the same side. So this is one important thing which tells us that there is a double barrel sign which is onto the same side, and this is pertinent to right isomerism. Now coming to the other things that we are going to look for is, as I said, whenever you see the posterior aspect of the left atrium, you definitely would like to demonstrate at least 2 pulmonary veins entering into the left atrium. And whenever you don't find them entering into the left atrium, and at the same time you find confluent pulmonary veins, or we have a vertical chamber, then we need to think in terms of a possible total anomalous pulmonary venous drainage. Now, so what we have is a factor which is up our sleeves. This is what is called as the area behind the heart. Remember now, whenever you try to evaluate a 4-chamber view, since from tomorrow morning, you please start having the area behind the heart as a check in one of the points in the checklist. So that will help you a lot in evaluating this particular area, which gives you a lot of clues in diagnosing many complex cardiac abnormalities. Now, how are we going to approach this? First and foremost thing, we need to know the normal anatomy of this area. Second important thing is we need to know the normal variations which can cause pitfalls. And at the same time, we need to know the abnormal findings and identify the limitations of this one. And using these subtle signs, we can use it as a screening tool in identifying or extending our examination to other areas in order to come to a considerable good diagnosis. Now, this is a wonderful paper that has been published in 2007 White Journal by Berg et al., where they have evaluated 613 fetuses with congenital heart diseases, of which almost 69 cases were having some subnormal finding in this particular area behind the heart. So this area with subtle signs, they help us in identifying congenital heart diseases in a normal looking 4-chamber view. That is one most important thing that we have to deduce. That was the conclusion made by this particular the article. Now, coming to the anatomy of the area behind the heart, we have the area behind the heart, as you can see very nicely. That is the left atrium, that is the flap of the foramen ovale. And then you find 2 twigs which are entering into the left atrium, that is the pulmonary veins. And just behind it is the aorta, this is the spine, and it's just left to the aorta. So the descending aorta is left of the aorta. And then associated with it, just anterior and to the midline, what you find is another rounded structure, which may or may not be seen depending on the distension of the esophagus. And this is particularly the esophagus that you normally see. And then there is another small structure which is seen to the right of the spine, which is actually seen only when you have a high resolution scanner. This is nothing but the hemizygous. So these are the things that we have to keep in mind while we are evaluating. So these are very simple structures that you are trying to build. First and foremost thing, you are going to look for the pulmonary veins. You are not going to look for the descending aorta, its location. And then you are going to look for the presence or absence of the esophagus, whether there is persistently seen or not. Then you see the hemizygous, which is normal, but whenever it is dilated, you need to think in terms of a possible abnormality. So this is how you are going to approach this particular thing. Now, coming to the anatomy on ultrasound, where we can nicely see that this is the left atrium. You can see 2 pulmonary veins opening into it, and that is the descending aorta, and the aorta onto the right of the left of the spine. And just above and anterior to it, if you can see, now and then it is appearing, that is the esophagus, and this small structure which is seen just behind or to the right of it is the hemizygous. So these are the structures that we need to evaluate whenever we try to evaluate the area behind the heart. Now, if suppose in case whenever you are seeing the 4-chamber view and you find that the aorta, that is the descending aorta, is onto the right of the spine, as you can see here, that is the vertebral body. This is the 4-chamber view, and you can see both the pulmonary veins nicely seen. But at the same time, you can see that the aorta is almost at midline or slightly towards the right of it. So this is the one which prompts you to thinking of a possibility of a right-sided aorta. If it is a right-sided aorta, the possibilities are it could be isolated incidence, or it could be associated with double aortic arch. And whenever you find a right-sided aorta, you need to keep in mind that there is an association of almost 25% with the conotruncal abnormality. So this is one thing which gives you a clue to further evaluate regarding the outflow tracts. Now, coming to the other aspect of it, whenever we find the right-sided aortic arch, the right-sided aortic arch could be associated with the presence of right-sided ductal arch also. As you can see here, both the arches are onto the other side, and it forms what is called as the V sign, and it is almost 90% of the times it is associated with the congenital heart diseases. Whereas, when you have a situation where there is a right-sided aortic arch, but the left-sided ductal arch, you find what is called as the U sign, where you can see here, you can see this U-like appearance, and it's almost 50% of the time is isolated, and sometimes it is associated with 22q11 deletion or downs. So these are the things that we have to keep in mind, and this is classical U sign that you see, that you find. So this sort of information can be obtained by just doing a conventional 4-chamber view and looking for the area behind the heart. Now, once that is over, for example, as you can see here in this particular case, we have the 4-chamber view, which is absolutely looking normal, except that there are two important features that you have to keep in mind. One, you can see that the aorta, descending aorta, is almost on this vertebral body. That is one. Second thing, if you draw an axis of the heart, it is definitely a left axis deviation. So these are the two subtle findings which have prompted us to thoroughly evaluate the conotruncal abnormalities. And at the end of the day, this is what you see while evaluating properly, that you can find a phallostetrology. So this is one thing which we have to learn, because that gives you a clue and alerts you to look for various conotruncal abnormalities. So this is how it is going to help us in evaluating this area behind the heart. Now, coming to the other structures which we find is the dilated azygos. Now, whenever we see a double barrel sign, as you can see here, that is the aorta as well as the azygos being prominent. Now, as I said, in a normal 4-chamber view, what happens is you do find that there is a small azygos seen adjacent to the vertebral body, particularly onto the right side. But this is actually the abdominal section, where normally you should see the aorta onto the right side and the inferior vena cava to be anterior and to the right of the vertebral body. Whereas here, they are parallel to each other. This is the classical double barrel sign. The reason why it is distended and it looks prominent is because whenever there is an interruption of the IVC, what happens is the systemic venous drainage starts draining through the azygos from the renal veins. It drains into the azygos system. So the azygos system becomes prominent, and this drains in turn into the systemic circulation, right? That is the superior vena cava. So this is a classical example where the abdominal section showing you the double barrel. At the same time, you take the sagittal section, you can beautifully see that there is an abrupt interruption of the inferior vena cava. And when you do the color Doppler, you can find that as a hemiazygos, the azygos is becoming prominent and it is draining into the superior vena cava. So these are the things, and not only that, you can see this double barrel having two different shades, because one is towards the heart, and the other one is towards the lower body. So this is how you try to evaluate, and this is classically the intrahepatic IVC is absent, and we have the renal veins that get connected to the azygos system, and that is the reason why you have a prominent azygos vein. Now, this is again another case where we have a double barrel sign, where we can see that the area behind heart, we can beautifully demonstrate the 4-chamber view. You find two vessels draining into the left atrium, and now you can see that there are two vessels which are just adjacent to each other. And this is classically, you can see the sagittal section, where you can see the ductus venosus opening, or the umbilical vein directly opening into the right atrium, and you can see both the aorta as well as the azygos vein very clearly delineated. So this is classical interrupted IVC, which is very often seen in the left isomerism. Now, coming to the left isomerism, not only that we look for those things, but once you have found that there is a possibility of the interrupted IVC, then we need to even think in terms of possibility of identifying the identifying the appendages. Now you can see beautifully the left atrial appendage on the right side. So that is nothing but more of left structures being prominently displayed, where you have instead of the right atrial appendage, you find the left atrial appendage. But then it is very difficult to identify this particular feature. So that is the reason why you first and foremost thing try to evaluate the double barrel sign, try to see the inferior vena cava. If it is interrupted, then you know that you are dealing with a possible left atrial aneurysm, isomerism. Now, there is a point which we have to keep in mind, that when you compare the left isomerism to the right isomerism, most of the features are seen almost similarly, except that there are few things that the heart blocks are present with left atrial isomerism, whereas in the right atrial aneurysm, you don't find them normally. The appendages are seen, 2 left atrial appendages, whereas in right atrial isomerism, it is 2 right atrial appendages. Now, the most important thing is that the multiple cardiac defects are present in both left atrial isomerism as well as the right atrial isomerism, but they are more severe in the right atrial isomerism. Now, coming to the cardiac defects, the commonest one is the AVSD. And then the right isomerism will have a single ventricle, pulmonary stenosis, atresia, TGA, juxtaposition of IVC, and descending aorta. Now, you need to understand that the presence of double barrel sign, which could be because of interrupted IVC, where you can see both the vessels, one by the inferior, one by the aorta as well as the azygos. Whereas even in the right atrial isomerism, you do find that there are malposition of IVC and the aorta. The most important thing is that they are to the same side. That is one most important thing that we have to keep in mind. And that is one thing then, whenever we have a doubt, because of the asplenia and polysplenia, whenever you try to evaluate, you can take what is called as the stomach distance, or which is called as the SDR. And this SDR is basically that in particularly the right atrial isomerism, we find that the SDR, that is the distance from the spine to the stomach, the center of the stomach, and taking the abdominal circumference into consideration, you can calculate the SDR. And once the SDR is more than 0.34, you know that you are dealing either with a normal fetus or with a left isomerism. Whereas if it is less than 0.34, then you know that you are dealing with a right isomerism. This is one point which can differentiate one from the other, even though it is not captured into area behind the heart. Now, other important structures that we have to keep in mind is the dilated esophagus. Now, whenever we have a structure which is just behind the left atrium and anterior and to the midline is the esophagus. This could be because of the swallowing of the fetus, or it could be because of lower esophageal obstruction, or it could be because of gastric or duodenal obstruction, and it is invariably associated with polyhydramnios, not during fetal swallowing, because sometimes you do find them during the fetal swallowing also. But here, how to differentiate one from the other is what is very, very important. Here you can see that this is the aorta and that is the esophagus, that you can see it very nicely. And there is definitely polyhydramnios with particulate material. Now, how to differentiate one from the other? That is, you can get confused with the double barrel sign, where one could be the aorta and the other one could be the azygos continuation. But the most important thing is the position of the cystic area, that is the tube that is there, or the structure which is there. Not only that, the peristalsis. The esophagus is always anterior. At the same time, it will be distended, and it can collapse, because as the fluid passes through, it gets collapsed. So, but then most important thing is whenever we have a interrupted IVC with the azygos continuation, in that situation, there is no way that you can differentiate it. At the same time, whenever we have a esophageal obstruction, there will be a persistent dilatation. At that situation, the peristalsis may not help us, but the location of the esophagus is the one which helps us, that because the esophagus is always anterior and to the middle of the spine, and this one is the one which will give us a clue. Whereas in a azygos continuation, you do find another circular cystic area which is adjacent and to the right or anterior to the spine. So this is how you differentiate one from the other, because this is an extremely important thing, because they are dealing with the entirely different two pathologies. Now, when we have this sort of a thing, as you can see here, we can see as the fetus is swallowing, you can see that the distension is there. At the same time, it gets collapsed when once the peristalsis passes through. Or, as I said, it could also be because not only because of the distal esophageal obstruction, but it also can be because of obstruction to the the duodenum or the gastric outlet obstructions. So these are all the situations where we do get now. Sometimes we have a tricky situation where you may find there are three tubes. As you can see here, this is the left atrium, that is the pulmonary vein. You have three tubes here. One could be the descending aorta, the other one is the esophagus, and that one is the hemiazygos. So these are the things that we have to keep in mind and should not get confused whenever you see this sort of three tubes. But occasionally you may get, in particularly the left isomerism, you may have a double barrel sign because of the azygos continuity, and intermittently you find the esophagus getting distended, and that's when you again get into trouble in identifying these structures individually. But again, at that situation, the location is the one which will definitely help us, and the peristalsis is the one which differentiate one from the other. Now, other situation is that when we have this sort of the area behind the heart, as I said, another one which we have to, other structure which we have to thoroughly evaluate is the pulmonary veins, opening of the pulmonary veins into the left atrium. Normally, you can see them as a twigs on either side, and these twigs, when they are absent, not only that, when there is rounding or smooth rounding of the posterior wall of the left atrium, and you will find your confluent vessels, then you need to think in terms of a AVSD. So particularly when you see this particular case, where you can find that you can see that there is an AVSD associated with it, you can find that there are two pulmonary veins which are joining together, which is called as the confluent vein, and that can be confirmed by doing a color Doppler, putting the color Doppler on also, and here you can find. But one important limitation or the pitfall which you should always keep in mind is you have to be careful about the fetal breathing movement. Particularly when we have a fetal breathing movement, there can be a mimic of a confluent vein. So that is one thing which you should always keep in mind. And whenever you have that doubt, it is better that you can take the spectral waveform in order to confirm whether it is because of the breathing movement that there is variation, breathing variation, or it is because of the confluent veins. So that is one thing that we have to keep in mind. And they are usually associated with complex heart cardiac abnormalities. We need to look for TAPVC and also associated with right isomerism. Now, factors which can diagnose the TAPVC are first and foremost thing that there is the absence of the normal tags of the left atrium, which I have already shown you. Not only that, the posterior wall of the left atrium becomes smooth and convex, and at the same time, inability to demonstrate the opening of the pulmonary veins into the left atrium. Not only that, the most important thing is presence of retrocardiac confluent vein, or sometimes it can even appear as a chamber or a vertical vein in the retrocardiac space. So this retrocardiac or the area behind the heart is the one which gives you the clue and you can easily identify it. For example, this is a classical appearance of a normal heart, four-chamber view, where you can see the descending aorta, that is the left atrium. You can see the convexity here, and you can see both the twigs of the pulmonary veins, as you can see in the color Doppler also. Whereas here, you find there is a rounding, smooth rounding of the post. This is the descending aorta, so smooth rounding of the left atrium. And here you can find the confluent veins. Confluent veins can be seen, and you can also see the vertical vein which is seen entering into the left atrium. And this is the same thing where you can see a confluent vein and the vertical chamber which is forming, and it's a total anomalous pulmonary venous drainage which is responsible for these features in the area behind the heart. So to conclude, the most important message which I would like to put across is location of the aortic arch. If it is, whether it is right-sided aortic arch or not, that is one thing. Presence of more than one vessel. Is it a dilated azygos in interrupted IVC, or with azygos continuity, or malposition of inferior vena cava? Presence of peristalsis, which is because of the dilated esophagus, or abnormal LA with confluent veins in TAPVC. So these are the most important things that you look for whenever you are doing a four-chamber view, and please include in the checklist of four-chamber view to look for the area behind the heart. Thank you very much.
Thank you very much, sir. I think you've motivated a lot of people today to basically, at least for a second, take a look at the area behind the heart. And I think if everyone starts doing it on a daily basis from, tomorrow, they'll realize that over a period of time, they're picking up a lot of these pulmonary venous abnormalities. And in fact, a lot of times you get the clue towards the left atrial isomerism, from the area behind the heart. Thank you very much, sir, for your presentation. Now we have Dr. Aniruddha Kulkarni, who's going to take us through, we see on a routine when we doing early pregnancy scan, there are times when we see that the sac is looking a little low placed or implanted lower down, and then the whole process starts in your mind what this could be. And Dr. Aniruddha is going to take us through those, an approach to a low implanted sac. Dr. Aniruddha Kulkarni, you can share your slide. I have a surprise guest by, Dr. Khurana just said that you need to have your discussion with your genetist. And coincidentally, I'm the luckiest guy. My genetist is my neighbor. So and a very, what a surprise guest after a long time lockdown. And I have my genetist sitting behind.
Thank you, Bimal. I think, am I audible? Is that okay?
Yeah, very much.
Okay, so the surprise is not only the guest, but the surprise is also in the fact that Marathwada chapter of Society of Fetal Medicine wants to felicitate Dr. Bimal Sawhani, who is a great friend of mine and motivator and teacher for so many people across country as well as in my region. So, so we planned this surprise well in advance in last 2-3 days, and just to put it across. Dr. Bimal Sawhani is a person regarding whom everybody wants to talk.
What do Dr. Bimal Sawhani, sir? A person in whom excellence and humility is personified. What sets him apart is his ability to form bridges between different disciplines, form a cohesive unit between different people, and lead by his own example. A son of the soil from Aurangabad, Maharashtra, he has done us all proud, and all of us will strive to maintain the high standards set by him in ultrasound and fetal medicine. Abhinandan, Dr. Bimal sir, for being elected as President of Society of Fetal Medicine, India.
I think most of us has seen Dr. Bimal Sawhani speaking from podium, addressing to the bigger audience. But there are certain other facts probably very less people might be knowing. He's a great friend. He's a great company in most of the conferences. So let us listen from Dr. Balaji.
Oneself as a guiding light and having a large number of followers is an incredible achievement. Bimal sir has achieved this in our Marathwada region and subsequently across the nation. Such a tremendous feat is possible only when one possesses excellent virtue. It is due to him that a lot of us have developed interest in fetal medicine and have become more methodical, which is also helping us in our other radiology work and day-to-day life. He is a patient listener, lending his ear to everybody, including newcomers, which makes him an affable personality. His skills extend to acting and directing, complementing his orations in his talks. And to add to that, he is also a good table tennis player. Well, on behalf of all of us, I heartily congratulate him on his selection as a President-elect of the Society of Fetal Medicine of India. Proud of him, sir. I wish him many more successes in the future, which automatically will lead all of us to greater heights. Thank you.
So he's a great foodie, enjoys food in all across the country, and he himself is a great host for that matter. He loves cricket to extreme extents. I mean, I have seen him sitting at 3 a.m. in the morning waiting for the. And not only that, he's a great actor and director. During his college days as well as in early part of his career as a profession, he started off with few TV serials. And I started my friendship with Dr. Bimal Sahni from year 1997. And I really enjoyed being his company to so many events, as well as so many traveling journeys, and being room partner at many occasions as a faculty. So I really congratulate from bottom of my heart to Dr. Bimal Sahni for being elected as President-elect of Society of Fetal Medicine. And may his graph continue to grow, and we are really proud of him. So congratulate Dr. Bimal Sahni for his finest achievement, and let the things get rolling for next many more years to come, and he may reach to probably the best places where he wants to reach, whatever he has dreamed in his own entire career. So in next 10-12 minutes, I will just wrap up, because I think it's already 9:45. An approach to low implantation of a sac. No financial disclosures, no corporate issue.
1 minute.
Hello?
Give me 1 minute.
Hello?
Yeah, you are audible, Aniruddha.
No, I think somebody says...
Connection there.
Should I continue?
Yeah, please.
Okay.
Let's do this.
Hello?
Aniruddha, wait a minute.
Okay, I should wait a minute. Okay.
Yeah, she's felicitating sir.
Yeah. So that this has been my privilege to give him this one patra on behalf of Society of Fetal Medicine, and he has been a great friend and a person that we all have acknowledged. Thank you so much, sir.
Thank you very much. And Aniruddha, you continue, because I become a little emotional. I'll speak afterwards.
Okay, no problem. So just I think in continuing our academic content, for that matter, no financial disclosure, no corporate issues. The things which have been taken as a contribution from other has been duly acknowledged as far as adoptions are concerned. Whenever we start evaluating early pregnancy, our first duty is to state that the implantation of a blastocyst is in upper part of uterine cavity, and we say that decidual reaction is adequate. In earlier part, it's interdecidual sac sign positive. Then we say about, say, double decidual sac sign. Then we say fetal pole along with activity is present, and then we move on. But when we say that the implantation of sac is in lower segment, that means that we have entirely ruled out all these entities, anterior, fundal, and the other entities, and we are more worried about implantation of sac in this segment. So the segment which is closer to internal os and lower segment, and in the cervical component of the myometrium. So if the implantation of a gestational sac is 5 centimeter or less from the external os, we call it as a low implantation sac. Here you can see that as we measure the distance from the external os, the tropoblastic rim is 5 centimeter or less from the external os. So our intention has to differentiate it from what you can say milder variety like cervical stage of miscarriage, or it could be a precursor of morbidly adherent placenta in subsequent time. But two most important dreadful conditions are cervical pregnancy and cesarean scar pregnancy, which needs to be addressed well. Most of the times when there is a low implantation of sac, whether it's an abnormal or a normal sequenciation, may present with bleeding PV or a pain. Now, as we have concluded that we are dealing with low implantation of sac, there are two things which we have to state: whether the sliding sign is present or not, and what is the status of a crossover sign or a COS. During transvaginal dynamic ultrasound, the suspicious area, that is the gestational sac, should slide over the cervical canal or a myometrial strip. Then we say the sliding sign is positive. But when the suspicious gestational sac is fixed and moves along with the dynamic pressure over the cervical canal, we say that the sliding sign is negative, which means the inability to displace the gestational sac from its position at the level of internal os using gentle pressure applied by the transvaginal transducer says sliding sign is negative. So what is the approach or a practical assessment tips when we by eyeball technique feels that it's a low implantation sac. So there are two things which I need to look at. If there is a presence of a tropoblastic flow around the gestational sac, which is low implanted, then the approach is different. And if there is absence of peritropoblastic flow on transvaginal ultrasound, the approach is different. So if it is flow is absent and the sliding sign is positive, then it is probably cervical stage of a miscarriage. But when there is a peritropoblastic flow activity seen on a color Doppler and the sliding sign is negative, then I need to consider these three conditions. That is gestational sac in the cervical myometrium, gestational sac near the deficient myometrium, which is 1 to 3 millimeter in nature. So we say it's a scar pregnancy, or gestational sac in which the cervico-isthmic junction tropoblastic activity is noted, where the myometrium anterior to it is more than 6 millimeter. So these are the three conditions where there is a presence of a tropoblastic activity, color flow. The sliding sign is negative. So I need to address these three issues, of which it is a cervical pregnancy, caesarean scar pregnancy, or subsequently becoming morbidly adherent placenta, for which, depending upon the first trimester ultrasound characterization, I should watch for second and third trimester ultrasound characterization, like heterogeneity of the placenta, presence of a placental lacunae, loss of retroplacental halo, and in later course of time, abnormal branching vascularity starting from placental substance entering into the myometrium substance, or maybe in later period of time, signs of accreta or a percreta. So whenever we are dealing with presence of a peritropoblastic flow, sliding test is negative, two things needs to be considered immediately. Look at the history sheet for multiple uterine scars or uterine instrumentation. And secondly, apply the crossover sign criteria. So whenever you apply crossover sign criteria, you are assessing the gestational sac tropoblastic activity in cervico-isthmic junction where the anterior myometrium is more than 6 millimeter. So what is crossover sign? On transabdominal scan, we take a sagittal section. Then there is a one line which passes from the fundus through the internal os, and there is another line which passes through the gestational sac from superior to inferior aspect. So if this red line, that is the gestational sac, is more than 2/3 above or superior or anterior superior to this yellow line, then probably the prognosis is poor. We are dealing with crossover sign stage 1. Now, if it is less than 2/3, then we are dealing with crossover sign stage 2, where the sagittal line and the red line needs to be drawn like this on transabdominal scan. Now, the entity which more or less is like inevitable abortion or products of conception in cervical canal is labeled as a cervical stage of a miscarriage, where the products or the sac or the detached sac is seen in the cervical canal inferior to the internal os. So usually it is detached from the fundus, so you will not get any peritropoblastic activity, color flow in such gestational sac or products. So basically we are dealing with a non-viable products. Usually the cervical canal is ballooned and the products or the sac is held up by the external os, which is usually tightly closed. So the most characteristic finding when we want to say that it's a cervical stage of a miscarriage is that there is no peritropoblastic color flow within the content of the cervical canal, which is showing classical balloon approach. So here you can appreciate that the products or the detached sac is over there. There is a cavity is empty. Here you can see that the cavity also is ballooned as well as cervical canal is ballooned, and there is heterogeneous products of conception like areas occupying in the cavity as well as in the cervical canal. So we are dealing with inevitable miscarriage in the cervical region. Then we come to second most important entity, that is called as cervical pregnancy. So the visualization of a gestational sac or a tropoblastic activity below the level of internal os. But remember, it's not easy to demonstrate the internal os in many situations. So what is the trick behind that is that internal os or the internal cervical os is an area where there is a uterine artery insertion. So either you look for internal cervical os or you look for uterine artery insertion and just look where exactly the gestational sac or the tropoplastic activity is noted. On three-dimensional approach, you can see hourglass type of a cervix. So we are dealing with a gestational sac within the cervical canal where adequate amount of myometrium is well appreciated anterosuperior to the gestational sac. At the same time, the gestational sac along with tropoplastic activity is inferior to the internal os, which is identified by the insertion of the uterine arteries. So we need to differentiate cervical pregnancy from other non-specific conditions like polyp. On many occasions, you will find that the uterine cavity is empty. There is a hypoechoic to anechoic areas, which is causing ballooning appearance in the cervical canal. On many occasions, if you are fortunate enough and it's a submucosal pedunculated fibroid or a polyp into the cervical canal, you might see a vessel over here. But most of the times, in such patients, urinary pregnancy test may be negative or beta HCG may not be corresponding to that. So basically, demonstration of a healthy myometrial slide is noted between the tropoplastic reaction, unlike in cases of a caesarean scar pregnancy. Coming down to entity, that is a caesarean scar pregnancy, we all know that the number of scars over the uterine segment are on the rise, and so are the two important conditions. One is placenta previa and its complications like percreta, accreta, and increta, as well as the caesarean scar pregnancies. Here we get an empty uterine cavity and a cervical canal. The gestational sac and the tropoplastic sac embedded maybe within the LSCS scar with a heterogeneous, irregular, thinned out myometrial stripe. But always remember, the anterosuperiorly placed myometrial stripe is usually less than 3 millimeter. The peritropoplastic active color flow is essential, which is usually a high velocity flow and low impedance type of a flow. Now, as the transvaginal ultrasound started evaluating caesarean scar pregnancies into detail, few people, they have labeled two entities of caesarean scar pregnancy. One is endogenous, where the implantation is within the scar, but the growth or the progression of caesarean scar pregnancies into the uterine cavity. And other is an exogenous one, which usually leads to most of the complication, is where the deeply embedded chorionic tropoplastic activity within the scar grows anterosuperiorly into the bladder substance. So we have an endogenous CSP and an exogenous CSP. Now, as people started evaluating the caesarean scar pregnancy, they have given a lot of importance in terms of how much myometrium is thinned out and how much it is involved. So they have graded the issue depending upon involvement of the myometrium and bulge of the scar pregnancy into the myometrial substance. And the highest grade one is an amorphous tumor like a mass with a rich abnormal branching vascularity causing bulge over the bladder surface or on many occasions intruding into the bladder surface as well. So we have a grade 1, grade 2, depending upon the involvement of myometrium 50% less or more. If there is a bulge into the myometrium, it is grade 3. And if it is an amorphous tumor-like mass with rich vascularity causing bulge as well as intrusion into the bladder serosa, then it is probably we are dealing with the higher grades. Now, when we should suspect the caesarean scar pregnancy? Normally, when the implantation of a gestation is high up, we need not worry. This is a typical scar which is seen where you can see there is a heterogeneity or some amount of hypoanechoic element closer to internal os. And this remaining portion could be a hyperechoic, transient, fibrous type of reaction over here. Okay, so we all must train ourselves to demonstrate how does a normal uterine scar looks like in a non-pregnant state. Then only we can demonstrate it well in a pregnant state. Now these are the three entities where here it is just kissing or brushing the lower segment scar section. Here it is partially involving the scar, and here the tropoplastic implantation has occurred within the scar itself. So here you can see there is a little bit of tenting over there. And now in cases of a caesarean scar pregnancy, if you are fortunate enough, you can see that there is a remarkable thinning of the anterior myometrial substance over there. there is a classical chorionic activity noted along with the yolk sac involving the caesarean scar area in anterior lower segment. So as soon as you demonstrate a classical caesarean scar pregnancy, we all must know that we can do intervention by using transvaginal route. So you can put a needle via transvaginal route. You can introduce methotrexate into that area. So you can just little bit nibble over there, aspirate some content and introduce methotrexate into that. And along with localized methotrexate into the scar zone, we can always give injectable intramuscular methotrexate and subsequently follow as we follow in cases of tubal pregnancy as far as subsidence of beta HCG level by 15% in a subsequent beta HCG assessment. So net result usually is falling down levels of beta HCG as well as disappearance of a classical features from the region of say chorionic activity involving the scar to subsequently a chronic hematoma involving the anterior lower segment. So I am thankful to Dr. Prashant Ingole because he sent me one case stating that there was a case of caesarean scar pregnancy. I have put in a Foley's bulb over there and just check whether the subsequent ultrasound shows disappearance of caesarean scar pregnancy or not. So he also sent me the article stating that how do you identify the scar pregnancy and how you can manage with the 12 French 10 ml silicone balloon catheter, and you can keep it for 2 days, and subsequently because of the pressure necrosis caused by the inflated bulb in the cervical region, the caesarean scar pregnancy initially gets compressed, get necrosed, and as you remove the Foley's bulb later on, it eventually leads to hello.
We are not seeing your PowerPoint.
Yes.
Yeah. I think it got closed. Yeah.
Got closed mostly. I think yes. Okay. Sorry. Okay. Yeah. So this was the patient. Now here you can see that this is a typical caesarean scar pregnancy where the chorionic tissue is well noted and it is getting tented or adherent and getting invaded into anterior lower segment scar over there. So after putting this Foley's bulb into that, keeping it for 2 days, later on subsequently there is a passage of blood clots along with the products because of the pressure tissue necrosis at that zone, and eventually little bit of hematoma was observed in that zone. And here you can see there is a little bit of fat indentation into the scar zone. So this is one of the ways by which we can treat clinically stable conditions of caesarean scar pregnancy as far as ablation is concerned. Now, on many occasions, either after treating them with a methotrexate or they may land up into your own clinic as a exuberant hyperechoic chorionic trophoblastic mass, which is invading the myometrial substance involving the anterior lower segment scar. Here you can see that the vascularity involving that scar zone as well as the mass of chorionic tissue in the scar zone is quite exuberant. So this is probably we are dealing with grade 4 kind of a caesarean scar pregnancy where because we are not able to demonstrate the bladder, but transabdominally we could have easily demonstrated the invasion of this tissue involving complete loss of myometrial stripe as well as protrusion beyond the uterine component into the bladder zone. So this was the histopathological appearance, and even you can see on the cross-section histopathological approach, it's a classical scar pregnancy which is seen. Now the last entity which needs to be discussed is a precursor of morbidly adherent placenta. As we have seen earlier, that as the number of caesarean scars are on the rise, the placentation abnormalities and the placenta previa related abnormalities are on the rise. So advanced maternal age, multiparity, intervention in terms of a multiple medical termination of pregnancy, previous history of placenta previa or abnormal placentation or placenta accreta, and most importantly, the uterine scars. So uterine scars may be myomectomy scars or the caesarean section scar. So these all are definitely precursors of the presenting future morbidly redundant placenta. So the most important criteria which has been mentioned in the literature is that the anterior myometrial stripe, if it is less than 5 millimeter in early pregnancy where there is a low implantation of a gestational sac. Secondly, we should always consider the crossover sign, which we have seen that from the fundus to the internal os, one line is drawn. There is another line which is drawn from the superior to inferior part of gestational sac diameter. And if the gestational sac is more than 2/3 above the yellow line or the sagittal line, then definitely we can consider probably that it's a precursor of a morbidly adherent placenta, which is going to happen subsequently in second and third trimester. Again, in second and third trimester, we should always look for, number one, homogeneity of the placenta. As it becomes more heterogeneous, in cases of placenta previa, we should always start suspecting something abnormal might happen. And later on, presence of a placental lacunae or holes, loss of retroplacental halo, abnormal branching vascularity starting from placenta into the myometrial substance, and furthermore involving the bladder surface serosa as the bulge of the morbidly adherent placenta goes on invading into the bladder substance. So first in early pregnancy, low implantation sac, check with the anterior myometrial stripe, check with the crossover sign, and subsequently follow all those patients in second and third trimesters. So low implantation sac less than 5 centimeter, and in many patients you will feel that the lower margin of the chorionic chronotrophic activity is being deviated or tethered or being attracted toward the anterior lower segment scar area. And in all those patients, we should closely follow those patients for abnormalities of placentation or morbidly adherent placenta. So on transabdominal scan, you can see that it's a low implantation sac, but here the low implantation sac is more closer to the anterior lower segment scar, more or less. So this is how the crossover sign which we have seen earlier. So what are the most practical approach of looking at lower implantation sac issues? Number one is by eyeball technique, while transabdominal scan, just look at the sac, whether it is in the fundus anterior or closer to internal os. As soon as by eyeball technique you have realized that gestational sac is low in nature, you have not done any calculation, just look at the history sheet of the patient, check whether there are multiple scars or there are not. If there are scars, then again evaluate those normal or abnormal uterine scars on transvaginal ultrasound. Check with the history of placentation or placentation abnormalities in previous pregnancy. And again, the chances that it's a morbidly adherent placenta or placentation abnormalities in this pregnancy could be high if there is instrumentation and previous multiple scars. So as soon as you walk down the 2 steps, the third one is to measure the distances. So what are the distances that we need to measure? We need to measure the lower margin of the tropoblastic reaction from the external os. And again, if it is less than 5 centimeter, we see that it's a low implantation. And secondly, if it is less than even that, then we start thinking about some or the other complications of the same. The next distance that we need to look for is we want to exclude if it's not a morbidly adherent placenta, if it is not the cervical miscarriage kind of characterization, then we need to exclude 2 conditions. One is a cesarean scar pregnancy and second one is a cervical pregnancy. So in that case, we need to calculate the myometrial strip above the gestational sac or the chorionic tissue. Now, we need to differentiate between a cervical pregnancy and cesarean scar pregnancy. And again, in cases of morbidly adherent placenta, as we have seen earlier, we need to assess for the crossover sign. Now, then you follow the algorithm which we have discussed earlier. That is, if there is a presence of a peritropoblastic activity, if the sliding sign is positive, don't worry, it is nothing but cervical stage of a miscarriage. If there is a peritropoblastic activity, that means we are looking at some low implantation of the sac. If the sliding sign is negative, then we need to consider these 3 criteria. Look at the history sheet, look for uterine scar, apply the COS or crossover sign criteria, exclude that the gestational sac is because of abnormal cervico-ischemic junction location. If the anterior myometrium is more than 6 millimeter, then you think of precursor of morbidly adherent placenta, which needs to be followed subsequently in second and third trimester. If the gestational sac is showing deficient myometrium less than 3 millimeter in size, think of a cesarean scar pregnancy. If there is a ballooning of the cervical region where sufficient amount of the myometrium is well demonstrated, anterosuperior to the gestational sac or a chorionic tissue, think of a gestational sac in the cervical myometrium, think of a cervical pregnancy. So step by step, starting from an eyeball technique, taking lines, thinking of myometrial stripe anterosuperior to the gestational sac tropoplastic component, we can evaluate it subsequently in a better fashion. Now, I want all of you to probably to go through this article by Silvaraj and Ravi Lakshmi. So this is a very recent article, and there are a few contents in my talk which has been adopted from this presentation. It speaks about low-lying gestational sac in early pregnancy and algorithm approach with ultrasound markers. Most of the things, that is the sliding sign, the crossover sign, the measurement methods by which we can calculate the risk of different abnormalities of placentation has been taken from this article. There's one more article which speaks about low gestational sac in first trimester in all previous cases of cesarean section. What is a placentation abnormality incidence? I think we all need to follow this one article also. And there is one more article which speaks about integration of a first trimester assessment criteria for ultrasound staging, which subsequently may give rise to placenta accreta spectrum, that is the PAS, what we call in future. So thank you very much for your patient listening. Your kind attention is well appreciated. You can see some of those videos on my YouTube channel, and if at all there is any question, you can follow me on my email as well as my Twitter account. Thank you very much once again. Thank you, Dr. Bimal Sahni, as well as the Mindray and Medicines team for arranging such a nice webinar with very atypical topics of common interest. Thank you.
Wonderful, wonderful. When I thought about this topic, I knew you would come, because this is something which has always been a dilemma, and I think the way you have brought it up and you made it really, really, the algorithmic approach is wonderfully brought about, and I think it definitely is going to be a lot of help to everyone whenever they see a sac which is a little low placed or low implanted. And before I even go to the question answers, I want to thank the complete team of SFM Marathwada and all the members of this chapter who have actually, this is, I think, the best day of this lockdown 3 months. And when Dr. Alka Ekbote came to my house, she stays in my same township, and she said, "Sir, the net connectivity in my house is not good. So I thought I will watch the program from at your place." And so I really, I really believed in what she said, and because that is quite possible. So thank you. And see, whatever I have achieved is always because it has always, you can't do anything unless you have wonderful colleagues around you. And as far as my achievements in SFM are concerned, yes, it all the credit, goes to my mentors who actually, had the confidence that I could do. They picked me up from nowhere, gave me opportunities, allowed me to, come and speak on higher platforms, and then had the belief, Dr. Khurana, Dr. Praveen, they believed that yes, maybe, I could do something more constructive at the national level, and that gave me an opportunity to go up. And this would have never happened if, your own team in your own vicinity is not with you. And really, really thank everyone from there. And whatever else, there's so much now I want to talk about, but I will all text it in the Marathwada WhatsApp group, and I will write and do it. And thank you very much. And also, our dynamic secretary, Dr. Shilpa Satarkar, it's her birthday today. So on behalf of SFM, I wish Shilpa many, many happy returns of the day. Stay blessed and stay safe, Shilpa.
Yes, thank you, sir.
Yeah. And there are few questions. One for Dr. Ashok Khurana. Aplasia cutis congenita. Do we have anything which we can do? Can we pick it up on ultrasound? And what is its genetic relationships?
One major problem that the findings are not consistent. The second is that although it has a genetic basis, it's probably not only a genetic basis. And then there are multiple manifestations which can be of such a great variety. So most of the times you end up diagnosing it as a postnatal condition and not as an antenatal condition. So theoretically you can diagnose it antenatally, but it is not the simplest of things to do.
It is, I think if it's syndromic, then it depends on what are the other things, and it can be an autosomal dominant.
Yes, but the prenatal dysmorphic findings are so subtle that you can easily make a mistake.
And there is one question: are there any tests for autism? Prenatal tests.
Autism. We keep hearing about new genes. The problem that we must understand about autism is that it's not purely genetic, that it's multifactorial, that there could be things that are antenatal insults, which are non-genetic. It could be environmental, it could be hereditary, but not genetic. And therefore, currently, we have no robust marker for autism.
Can isthmosyle be considered as a differential diagnosis for a low implantation sac?
Can?
Isthmosyle.
Isthmosyle.
Isthmosyle. I think.
I think one of the rarest possibilities.
It's quite rare, but I think the basic intention of this talk was just to go systematically. Whenever you feel on screen that the sac is not where it should be. But yes, it's possible in rarest of rare possibility.
This question is to Dr. Khurana, sir. This is from Dr. Alka Bote, our genetist from Marathawada, from Aurangabad. Her question is: if single gene testing is chosen through NIPT, would negative report be considered negative?
Can we have that again? I missed the first part of the question.
If single gene testing is chosen through NIPT,
yes,
would negative report be considered negative?
No. When we do what we call the extended NIPT, and we're looking at not just a single gene report, but say other conditions, then a negative report would not be considered negative. It is truly just something which is not yet validated enough, not yet robust enough. And we must accept the fact that currently NIPT is an excellent test for trisomy 21, but for the extended part of the NIPT, which is the microdeletions as well as the single gene defects, we cannot accept NIPT as diagnostic or a high-level screening test. It's certainly nowhere close to 99, and we're still sitting at the chance of it going both ways. So we have to take it with a sack of salt.
The second part of the question is exactly under what sonographic markers can we guide this test in first or second trimester?
Can we say that all over again? In which?
There is some problem with the audio.
Yeah, your audio is not so clear, Vimal.
Not so clear, Vimal.
NIPT, under what sonographic markers can we guide this test in first or early second trimester? NIPT.
NIPT. NIPT is not truly to be guided by ultrasound markers. Yes, if we are not using NIPT in the true sense, that we don't use it as a primary screening test, then we first have our ultrasound stuff. If you have an ultrasound structural abnormality, NIPT goes out of the window. You have to go in for invasive testing. If I find a thick nuchal translucency, again, I would go in for invasive testing as the first choice. If I don't have any of these and I have a high risk on my first trimester combined screen, then I can use NIPT as a contingent test for somebody who does not want to undergo invasive testing. That is the only way of looking at it. That's the only perspective. Otherwise, the moment you have an ultrasound finding, we do not encourage NIPT.
Aniruddha, can you explain the sliding sign and its significance?
I think I will have to share the screen. Can I?
And then there is one more question. Explain the crossover sign.
Okay, that is one after the other only. Hello?
Yeah, you are audible.
Okay. So as we do dynamic transvaginal ultrasound during our ectopic pregnancy by giving bimanual pressure, like pressure from the pelvis, and then maneuvering the transvaginal transducer in the fornices. If the suspicious sac area can slide over the cervical canal or the myometrial stripe, we say that it's a positive. So we are not worried about positive test. We are worried about a negative test. So what does negative test means? That the suspicious or the case under trial gestational sac topoplastic part is fixed one, moves along with the dynamic pressure over the cervical channel is negative. So the inability to displace the gestational sac from its position at the level of internal os using gentle pressure applied by the T. So by applying both the pressure, that is suprapubic pressure given by the left hand and a transvaginal transducer, if we can move it, slide it, then probably we are not worried. If it moves along with the cervical myometrium, that means it's fixed to the cervical component, in which we have to consider two options. That is a scar pregnancy or a cervical pregnancy. This is as far as the sliding sign is concerned. And the next one is, I think, crossover sign. So in case of a crossover sign, we look at the sagittal section transabdominally. By eyeball technique, we have thought of considering low implantation gestational sac closer to the internal os. So after doing that, one line is passed from the fundus through the internal os, which is a yellow line. The second line is from superior to inferior aspect as we measure the gestational sac diameter. So suppose the gestation or the tropoplastic activated gestational sac is more than 2/3 above the sagittal line, which is the yellow line. Usually the prognosis is poor. That means we are considering two conditions. One is cesarean scar pregnancy. Second is cervical pregnancy. Okay. Now suppose cos, that is a crossover sign part 2 or grade 2, where it is less than 2/3 above this line, then probably we may consider the fact that there is a significant amount of the myometrial strip which is up above the superior margin of gestational sac or a chorionic tissue, in which we have to consider the fact that probably we may deal with the precursor of morbidly adherent placenta. Thank you.
Praveen sir, are you able to hear me?
Yeah, now I am able to hear you.
There's the one question is, sometimes when we look at the four-chamber view, we feel that the area behind the heart is increased, but when we look for the veins, we are seeing the veins, pulmonary veins opening properly in the left atrium. So how much significance we should give just to an increased area behind the heart?
It is not the question
distance. It is increased distance.
I know, I understand. And it is not the distance that is what is important. It is the structures that we are going to look for in the area behind the heart that is very, very important. The increase in the distance or the increase in the area prompts you to look for these structures, particularly either the aorta, its location, or the inferior vena cava, or the azygos vein being there, present there, or the presence of a dilated esophagus. So it's not just the distance that is important. Distance tells you to look for all these things, and the identifying these structures and trying to categorize them is one which is going to help us in identifying the abnormalities.
Actually, I think when we take the four-chamber view, it is oblique, that time also, artificially you feel that there is an increased distance.
I know.
So I think we are through with the we are through with the questions. And I hand over to our secretary, Dr. Shilpa Satarkar, to propose a vote of thanks for a wonderful evening.
Thank you, Khurana sir and Praveen sir for those great lectures. Actually, I cannot help but acknowledge that every time after your lecture, the following years bring a very, very great academic and other opportunities for all of us at Marathwada chapter. Your lectures really open a gateway of our minds and impart upon us a very valuable knowledge that is extremely helpful in our day-to-day practice. And for that and everything else, we all thank you very much, sir. Thanks, Aniruddha, for the lucid and a concise talk. And thank you for your technological expertise for making the webinar and our online surprise felicitation program a great success.
No, that was your idea. Don't blame me for that idea. The entire idea
it was a team idea. Basically, it was our team idea, and it was really a wonderful feeling, you know. And then actually, before saying thanks to Sahani sir, I would also like to express my gratitude towards Shivani Sahani. Shivani, basically, she has to sacrifice her personal time with sir, and therefore we really get maximum academics out of her. So thank you, Shivani, so much. And Sahani sir, the intellectual cascade of fetal medicine and SFM you started here in Marathwada is now flowing laterally and in depth. And we promise that your dream to make this region the best in fetal medicine is bound to be fulfilled. And thank you very much for being our strong pillar. I also thank Medicines and the Mindray for powering our event. And thank you all attendees for joining this academic feast. Thank you, everyone. Good night.
The only thing that I'm worried about whenever there is something like this is it an indirect way of telling now move off?
No, never, sir. Never, sir. In fact, we demand more from you now.
I think he is forcing himself on.
No. A lot of times, you know, that's something that you're always worried about.
No. We can't lose you. We can't lose you.
No, absolutely.
Shilpa has done the right job in stating that now Dr. Dr. Shivani Sahani cannot say anything for at least next 6 months.
So that means we want more time from you, sir. And actually, it's really because of you that everything means we are day by day we are becoming so responsible towards fetus, sir, because all the teaching of SFM and all of you teachers.
I'm doing what many seniors did with us. See, it is just a vicious cycle which goes on. See, these stalwarts were sitting here. They did with us, me, Aniruddha. We benefited out of that. We tried to just pass on exactly what has happened with us. And I think, so this is how it just goes down from the top. Everything moves from the top. And so...
Absolutely, sir.
Hereditary.
Yeah, it is hereditary.
Yeah.
Thank you very much. Thank you, everyone.
Thank you.
Wonderful. Wonderful meeting. Yeah.
Thank you.
Thank you.
Thank you. Thank you very much.
Congratulations.
Yeah.
Thank you, Shivangi, and the complete Mindray team. With your permission, we would love to, now
log out.
Yeah, log out of this and have.
And thank the Mindray people also very much. Yeah.
Everyone is back to practice, so just practice safe. Take your all precautions and
stay safe.
Yeah, that's safety is more important than just doing the numbers there. Yeah.
We all want to see everyone on the screen in next so many years.
I know.
Thank you, sir. Thank you, Praveen.
Thank you.
Bye. Good night.
Good night.
Good night.
Thank you very much, sir.
Thank you.
Good night.
Good night.